the root of this question is what we've heard a lot about with regard to sequencing available therapies in the chronic GvHD, and whether you all have any approach or algorithm that you use at your center, or is it back to personal preferences? I'd like to hear some discussion and thoughts around that.
Well, I guess for Europeans, it's currently still difficult because, as Mohamad has said, we don't have the ROCK inhibitor available. So we don't have neither experience nor the option. We were in the ibrutinib study, but outside of the study are not really using it a lot. So our second line is ruxolitinib. What we do more frequently is the combination for chronic GvHD, for example, with ECP, since we are an ECP center. I found it also quite interesting, the retrospective analysis in acute steroid refractory GvHD, where ruxo is combined with ECP. So I think we are more interested in these combinations that can work out quite well. I would love to have a ROCK inhibitor, but I have no idea. So far, not even ruxo is approved by the EMA. So we do it outside of approval, basically.
So you have a good news, actually, Hildegard, that the CHMP gave a positive opinion, which obviously it will lead to an approval in a few weeks. I don't know when they will meet, but they gave a positive opinion. But I agree with you. I think ibrutinib for us is like anecdotal in terms of cases. It didn't really make it, the US approval to Europe. Belumosudil, at best, it's compassionate use. And I think it's probably there will be some trials in Europe. So it's mainly about ruxolitinib, I think, for most of us around the table.
I would say even in the US, ibrutinib is not as widely prescribed or used in that setting, in the setting of chronic GvHD or steroid refractory, or it may be used more at certain centers than uniformly across. So Hildegard, your approach is less in sequencing and maybe a combined approach with ruxo and ECP for refractory patients?
I mean, what I would be quite interesting to know is that's what we also discussed with Robert a couple of times in different meetings. Obviously, in this combination, they were able both for acute and chronic GvHD to taper steroids quite rapidly. So the Hamburg group for steroid refractory acute GvHD has these retrospective analysis with the severe gut involvement, where about a third of patients was under ruxo and then did not respond right away. And then they added ECP to it, and they were able to tape or get rid of the steroids within a month because that was their policy on purpose. And that, of course, could have a lot of advantages, as we all know, but could then also be part of why non-relapse mortality is lower. So I think what we could discuss is also do these steroid tapering schedules that we used to have. For example, where everyone felt only if a patient is responding after 5 days, you can decrease the dose by, let's say, 20% and so on. Still, patients have a long duration of steroids in the acute setting. So the question, I think, could also be, how much evidence do we have, or should we work towards getting more evidence that we can get rid of the higher steroid doses by combination? Or is the situation not different because ruxo is far more potent than what we used to have available, so that we can get away with the more rapid steroid taper?
So in that, it's the endpoint of interest is stopping steroids and the time to discontinuation, because ultimately I would think, whether a patient responds or not, as a matter of practice, especially in older patients, you have to taper the steroids. And for instance, at MD Anderson, we have just that, a tapered schedule for patients who have steroid refractory acute GvHD, that is, taper that calls for tapering, even in the absence of response, just because of you can't continue high dose steroids without seeing toxicity.
But I guess this is not so frequently done. I see it at our place that we have a lot of discussions about that. It was mentioned also when Paul Martin last year had this manuscript in Blood, How I Treat Steroid Refractory Acute GvHD, where he even mentions it. You should get rid of the higher doses. I'm not sure whether this has been recognized, or whether centers and people paid so much attention to getting rid of the higher doses. I don't know, maybe you can ask others, or at least I would find it interesting to look into that.
Does anybody else have a taper schedule for non-responders for steroid refractory?
I just, Professor Greinix, speaking about acute or chronic GvHD, because I am
acute mainly, because there we start with the 2 milligram.
Yeah. Regarding acute, I totally agree with you. I think that when a patient is resistant to steroids, that steroid doesn't work. And if we are going to start a second line treatment, and sometimes the third line treatment, you have to get rid of the steroid as soon as possible, and to stop them within a month should be what we should achieve all the time. So I am completely in line with you, and this is always what I say when I discuss with the teams, that we have to decrease the steroids very quickly in case the patient are resistant to the steroids. Regarding chronic, this is more tricky because sometimes more patients are more steroids dependent rather than steroid resistant, and sometimes it's more difficult to have this very quick tapering of the steroids.
Yeah, I don't think we have a strong evidence to say we should stop steroids within a month. I mean, I think that's a goal or an endpoint, but how do you measure that? It's very difficult. I've looked at various endpoints looking at cumulative steroid exposure as an endpoint, and it's very challenging to look at, because obviously patients who die from their GvHD at day 32 get less steroids than the person who's alive for 3 months, and the competing risks are very hard to account for. So objectively, it's very hard to publish upon the advantages or the benefits of following a prescribed taper approach in the setting of steroid refractory. It always seems to come down to expert opinion and positions like Paul put forth in his How I Treat paper. But I do think it's important, and I think people who treat a fair amount of steroid refractory acute GvHD recognize that you can't forget the patients on high dose steroids, and because of cumulative exposure, a patient on an extra week of 2 milligram per kilogram, that's and somebody doesn't taper, that's worth 2 weeks when they're at 1 milligram per kilogram or lower. So it's really those initial doses that contribute to the cumulative exposure. How about thoughts in the chronic setting? Does anybody else use or follow a different approach in patients with steroid refractory? Bipin, how about in the, you have access to, belumosudil as well as ruxolitinib and ibrutinib in the United States. Those are all three approved, and of course there's a handful of other therapies that commonly are used but are given off label. Do you have a approach at Vanderbilt?
I'm sure they have their approach. The problem is that all of these approaches are homemade, and my best guess, well, obviously in our JC or FACT accreditation, we all have these SOPs, I think. The problem is that even within the same center, I'm not sure that all the physicians are applying, meticulously all of these guidelines. That's my feeling. I think at best we can say, well, the goal, the philosophy is to achieve this. The way you're going to achieve it is going to be a little bit more complicated, and this will go anyway beyond the scope of what we're doing, but that's my feeling.
Sure. Yes, it's hard to put in the FACT and other SOPs. Recommendations that fall off of FDA approved. For instance, if belumosudil is approved for patients who've after 2 prior lines, whereas Rux and ibrutinib have, based on the studies, were approved for earlier. So it's hard to write into a SOP when to do that. Insurance companies, at least in my experience in the United States, don't understand the details and count lines of therapies when giving approval. So in practice, you could give belumosudil earlier or later or what have you with the other drugs. But it's hard to write a SOP where you deviate from FDA approved indication.
May I ask something else? Because all these drugs, usually in chronic GvHD, achieve partial resolution. What is not too surprising if you have very advanced, severe sclerodermatous chronic GvHD. When we had the first NIH consensus, the recommendation was to do response assessment every 3 months and to change therapy if patients are not responding. This was to a certain extent difficult, for example, for the ECP-treated patients, because there we know it sometimes for sclerodermatous chronic GvHD, it just takes a longer time. Would we or should we change recommendations now that we have other more efficient therapies available, although knowing that the vast majority of these patients also will have only partial resolution? So the question is, for how long do you continue with these new drugs in partial resolution, or when would there be a time point to have a change or to add to improve results? Do we have enough data currently that we can say something to that?
So I don't think we have enough data to speak to answer your question on when is the right time. We do capture in most of the prospective trials, progression-free survival, and most of the failures on that are because of starting second-line therapy. So we do have a good sense of what the practice is, but whether that practice is evidence-based or you can say that evidence supports that practice, I think is where the data is lacking. I think you do come across patients who are progressing their, have progressive chronic GvHD. They're, actively getting worse in terms of their sclerosis and having more skin involvement or more contractures or more impairment. And when you start a therapy and you see that stop, you are inclined to attribute the therapy that you started. And so while you may not be seeing a response, knowing that your patient who has quite explosive sclerosis that's progressing, you do tend to attribute response to your therapy or that outcome for your therapy. But what about others? Does anybody else have any guidelines on when they stop therapy after achieving a certain response?
It's Arnon. I don't have, but it's also can be different for various organs. So the patient may have, GI tract and skin, or lung and skin, and the response and the time can be different. So I just consulted 2 patients this week with bronchiolitis obliterans, and this is exactly the problem. They respond in the skin, but no change in the volumes in the lungs, spirometry. And then what you do with the steroids.
I would say that apart from ECP, the 3-month assessment, to your point, is I think that is a reasonable timeline. And if you see across 2 different assessments across 6 months, no change in practice, that's when we consider switching or starting a new line of therapy.
Yeah, I think these are part of the really difficult questions where there is no single answer. And I'm sure if we ask 10 colleagues, you will get probably 6 or 7 different responses.
But this, of course, also is related to the sequencing of drugs. So you basically, the first step is, when do you decide that the patient is steroid refractory, like chronic GvHD? The second is, for how long do you then use your first salvage, your second salvage, etc.?
Yeah, you're right. But here, I think maybe that makes me think about an idea that we need to emphasize and raise awareness about education, when to define refractoriness, when to change. And I think Dan Wolf recently, or maybe had a nice paper and some guidance about this. And because in general, my feeling is that we usually react very quickly, whereas maybe you should wait a little bit, and we always accumulate treatments, and which are not always useful. So maybe one deliverable of this discussion would be simply to go back to the basics about, I think I have 3 or 4 slides that Dan presented at the last EBMT meeting about, step by step, do this, don't do this, do this, don't do this. Obviously, there will be always this, miserable patient where you are not going to follow the rules, but that can be a good deliverable.
Yeah, I agree.
Yeah, many times, though, that's really going to be contingent on what you have available in your country or your center, whether you have a clinical trial that these patients could participate on, whether the patient is, able to come for your therapy. So there's so many variables that it gets hard to apply that broadly, I think.